Hey, Dipali.
Ma'am, shall we start or wait for Chitra? Shall we start?
Yes, sir.
Okay,
We
fine.
start, but I think Madam is speaking some.
Is Madam has to unmute?
No, I'm okay. I'm okay. I muted myself so that there is no disturbance from this end while you're speaking.
Okay, ma'am.
I'm following Zoom protocols.
Okay, ma'am.
Great.
So good evening, doctors, and I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. Topic for today's webinar is targeting vaginal microbiome for urogenital and reproductive health. I kindly request the participants to post their queries in the comment box so that at the end of the presentation, we'll be having a short Q&A session. And now it's time to introduce our eminent speaker for this evening, Dr. Nivedita Datta Madam. So thank you, ma'am. Thank you for accepting our invitation, and it's an honor to introduce you, ma'am. So doctor is the most renowned consultant gynecologist and obstetrician doctor in the city of Bokaro. And madam has involved in various academic activities like organizing conferences, and madam has presented paper at local and national level. Madam has presented paper in JOGA and palliative care journals. And madam is also training nurses on LR protocols. Madam is the Mayanta champion and coordinator for Jharkhand. And madam is a specialist in palliative care, and her interest is high risk obstetrics, infertility, and vaginal surgeries. Madam is also a member of various committees like Safe Motherhood Committee and Indian Society of Perinatology and Reproductive Biology, and SOVCI, IFS Food and Drug Committee, and Oncology Committee. So with this introduction, I welcome you, ma'am. I hand over the session to you, ma'am. Now you can start your presentation.
Thank you, Dr. Stalin. And very big welcome to all those present and listening, especially with this onslaught of hello. Yeah.
Ma'am, you can continue, ma'am.
No, I just would like to start sharing my screen so that it's not a problem later. Just give me a few seconds. I think my screen sharing has been stopped from there.
Yes, ma'am. You have not shared your screen, ma'am, but we can see you in the screen.
No, just a moment. I think I'll have to. Just a moment. Yeah. Sorry, it's. Yeah, okay. Now, can you. I think we can.
Yes, ma'am. Yes, ma'am. Your
Yes,
screen
ma'am.
is
Now I can
visible.
see you, ma'am.
Okay, now
Can
just.
you make
Okay,
it
fine.
full screen? Yeah.
Okay, fine. Sorry for taking these few minutes, but sometimes I have these technical glitches. Anyway, a very good evening to everybody present and listening. And it's an honor to be speaking in front of you in spite of an onslaught of so many webinars every day. In fact, I was just on another webinar right now on preterm labor by the Safe Motherhood Committee. And there I heard about, obviously we all know about the importance of bacterial vaginosis as a causative factor of PPROM. So this topic today, targeting vaginal microbiomes for urogenital and reproductive health, is basically taking you back to the basics for a better outcome for the future in obstetrics. We all know that alteration of vaginal microbiomes or vaginal dysbiosis, as it is called now, has huge implications in obstetrics and gynecology. What is important is to identify the risk factors, how to diagnose, and how to treat this, this pathology, and whether there is any rationale for the use of probiotics for the same. So, ladies and gentlemen, I begin my talk by introducing you to the basics of vaginal microbiota. What is microbiota? As you can see, it is like basically an ecological communities of commensals, symbiotics, and pathogenic microorganisms which are found in and on multicellular organisms. So basically, let's not confuse the issue. It is a combination of good and bad microorganisms which are existing on multicellular or tissue level organisms like the oral mucosa, the nasal mucosa, the conjunctiva, the skin, the gut, and the vagina. Most important thing is that the good microorganisms need to keep the bad or the pathogenic organisms under control. It is like the hero has to prevail over the villain, otherwise hell breaks loose. Now, this is a very congested slide, but it is all about what the good bacterial flora or the commensals are in various or tissues of the humans. So, since we are targeted to the vagina, let us think about the healthy vaginal ecosystem. Now, a healthy vaginal ecosystem is a dynamic equilibrium, which means that it keeps changing. It's not fixed. It has to keep changing between the epithelium, between the normal colonizing organisms, especially the lactobacilli, and the local secretory and cellular immune factors. So there are three factors between which this dynamic equilibrium has to coexist. And all three are responsible for maintaining a vaginal pH which is acidic between 3.8 to 4.2. This is what creates an unfavorable environment for the pathogen. So, let's focus on a normal vaginal flora, which is mostly made up of lactobacilli. You can see the picture, the background slide, and that is what lactobacilli and normal vaginal epithelium is like. So these are basically gram-positive rods excreting hydrogen peroxide and which affects the adherence of the epithelial cells. So what does it do? Now you will wonder why I'm taking into such details. But what does lactobacillus do? It basically is like a coating on the normal epithelium, which is preventing the pathogens from coming and attaching themselves to the epithelium cells. So that is how it protects against the bacteria and the candida infections. The major reason why I am taking you into this detail is basically if you do not know the physiology, it is very difficult to take care of the pathology. The facultative organisms, which are of less importance, are diphtheroids, coagulase negative staph, strep, E. coli, ureaplasma, and mycoplasma hominis. But our whole focus is on lactobacillus because that is the majorly predominant beneficial microbiota in the vaginal epithelium. So basically, as I said, it has to be a beneficial versus pathogenic or good versus bad. And a quick recap that maintaining vaginal hemostasis is mainly by the beneficial microorganisms lactobacillus, which maintains lactic acid and thereby maintains the pH between 3.8 to 4.5. And this lactobacillus also, the first is produces lactic acid and maintains the pH. Second, it produces hydrogen peroxide. And we all know the use of hydrogen peroxide. It also produces bacteriocins, which prevent bacterial growth. And it also does not allow attaching of the bad bacteria to the wall of the vagina by competitive inhibition. So these are all the methods in which the lactobacillus is going to act. Here, ladies and gentlemen, is the most important thing which has a protective role on the vaginal flora. The female hormone or estrogen, that is what facilitates breakdown of glycogen to lactic acid facilitated by lactobacillus. So estrogen is what protects the normal vaginal flora. And the abnormal pH, the aggravating factors could be one, low estrogen, two, any trauma to the epithelium, because I said dynamic equilibrium between the epithelium also. So any trauma to the epithelium, the alkaline seminal fluid, and anything which causes alteration of the vaginal ecosystem also causes epithelial desquamation. So here, estrogen, the factors influencing vaginal microbiota, the first thing you have to remember is estrogen has a decisive effect on the composition of the lower genital tract microbiota. The second one is ethnicity. If you see this graph, I mean, if it is clear to you, you will see that South Asians are a privileged lot. You can see that the green one is the lactobacillus and the red one is the organisms which cause bacterial vaginosis. So the ratio of green is to red is much more in South Asians compared to Africans, where the green and red are at more or less the same level. So we as South Asians have are anyway at a better status to have lower chances of bacterial vaginosis. So the factors which now are associated with vaginal dysbiosis would be, as you can see, the host genetics, the host demography as ethnicity, as I said, then the behavioral characteristics like sexual activity, which traumatizes the epithelium, smoking, hygiene activities, and some actions of the healthcare providers, like, sorry, the health person who is doing the other person, like lubricant use and antibiotic administration. All these affect the composition of the vaginal microbiota and thereby the vaginal pH. Vaginal hemostasis, as we have learned so far in all those slides, is a balance of the good bacteria versus the bad or the harmful bacteria, with the good bacteria prevailing over the harmful bacteria. Altered vaginal microbiota leads to a host of urogenital problems like vulvovaginal candidiasis, bacterial vaginosis, UTIs, PIDs, to name a few. The common causative organisms would be bacterial vaginosis, which accounts to nearly 40 to 50% of the cases, and this is what we are going to focus on today. The others are vulvovaginal candidiasis and trichomoniasis. A quick look at what could be the causative organisms and what you can as clinicians can see or can examine while examining a woman who comes to you with any kind of discharge. Please do not give a blanket treatment of the kits containing azithromycin, fluconazole, and tinidazole. Identify the cause. Look at her complaints. If she complains of bad odor, which especially increases after intercourse, think of bacterial vaginosis. If it's discharge and itching and burning, it could be candidiasis. Bad odor with a frothy discharge, pruritus, dysuria, spotting, trichomoniasis. And a thin watery discharge with pruritus is due to other bacterial infections. See the look of the morphology of the discharge. It could be thin, gray, or white in bacterial vaginosis. In candidiasis, which is very classic, we all know it, is a white cottage cheese like discharge. Trichomoniasis, we have been taught over the years, it is a green or yellow, frothy. You can see the bubbles in the vagina. It's a frothy discharge. And a bacterial discharge. Bacterial is not bacterial vaginosis. Other causes of bacterial infections, the sepsis, would cause a watery or a purulent discharge. Then, of course, we have the whiff test and the vaginal pH, which could be low even in candidiasis, whereas it is raised more than 4.5 in bacterial vaginosis, in trichomoniasis, and in bacterial infections. So we have those strips to test the pH, which you can test them with. You can see the look of the discharge, and you can also please give a patient hearing to what the woman has to say about the discharge and the smell of the discharge. The abnormal vaginal microbiota is basically because of a loss of lactic acid producing lactobacilli. Now, what happens? The pH gets raised, that makes it less protective, and therefore there is a higher proportion of the facultative Gardnerella and the strict anaerobes. Bacterial vaginosis, and this is in red because bacterial vaginosis is associated with preterm births in pregnant women independent of other risk factors, and hence BV, we are constantly on the go about it because of the increased incidence and the increased prevalence of preterm births in India today. So basically, BV is due to bacterial vaginosis, is due to an imbalance in the homeostasis, and you can see the bad bacteria has gained strength and is prevailing over the good ones. It is a serious burden to women of reproductive age, and around 30% of women suffer from it silently. The important implications, as I said, of bacterial vaginosis are increased susceptibility to STDs, including human papilloma virus and human immunodeficiency virus. Preterm labor, I've already mentioned. Infertility, failure of embryo implantation in IVF, recurrent pregnancy loss, pelvic inflammatory disease, postpartum endometritis. This is something which is coming out quite common nowadays. Now, postpartum endometritis. This is also an important cause of adherent placentas later. UTI. So, the implications of bacterial vaginosis is immense. Treating bacterial vaginosis has been shown to improve the pregnancy rate, as you can see in this one which has been treated and the ones which are untreated. So let's come up to the women who are at risk factors for bacterial vaginosis. I mentioned three things. One was estrogen is protective. So any state where the estrogen is lowered, whether it is in the menstrual cycle, also if you note, there is a time when the estrogen is lower, that is just before menses and during menses. So that is the time when again she is at risk for bacterial vaginosis. Anything menopause, she's at a higher risk of bacterial vaginosis. So, bacterial vaginosis prevalence is lower in women using oral contraception because it provides estrogen, although candidiasis takes an upper hand here. Again, during pregnancy, actually bacterial vaginosis is lower because estrogen is at a higher level. Again, here candidiasis is more important. But when bacterial vaginosis occurs in pregnancy, it is catastrophic. Clinical trials with estradiols can actually cure bacterial vaginosis by restoring the pH. Then risk factors are again race and ethnicity, where, as I said, we are privileged. Then frequency and the kind of intercourse. In fact, it has been shown that sexual intercourse, even once a week, was a high risk factor with a loss of hydrogen peroxide. Now, ladies and gentlemen, I am not asking for any abstinence. I'm just mentioning facts. Now, abstinence obviously is not the way out to get a risk to have no risk factors for bacterial vaginosis, but definitely promiscuity increases the risk factors for bacterial vaginosis. Now, what has been is the question is bacterial vaginosis a sexually transmitted disease? No, because bacterial vaginosis has not been discovered in the the bacteria for bacterial vaginosis has not been discovered in the seminal samples of the male partners of women with bacterial vaginosis. So it is whether it is an STD or a raise of pH is not is still controversial, but sexual factors, increased sexual habits, altered sexual habits do increase the chance of bacterial vaginosis. Now that we have covered the risk factors and what the major implications are, we come to the diagnostic aspect. When I mention diagnosis, the first thing coming into your brain is obviously the whiff test and the laboratory diagnosis. But we are clinicians first. And why has history taking? See, history taking and examination is now way below. It has come absolutely on the end of the list. It should be on top because symptoms and signs of bacterial vaginosis can actually tell you that it is bacterial vaginosis. And then you have other diagnostic tests like gram staining, culture, pH of the discharge, and diagnostic kits. as you can see from this slide, that when the normal flora or lactobacillus decreases, then the anaerobes will start increasing, and somewhere in between, the bacterial vaginosis will start becoming symptomatic. So what are the symptoms? Itching, discharge, where thick or thin, usually grayish white with a bad odor. Burning sensation which gets worse during micturition or coitus. Dyspareunia and dysuria, pain and discomfort in the pelvis, especially in the vagina. Then comes the diagnostic criteria. So the diagnostic criteria is by Amsel's criteria. And Amsel's criteria says that 3 out of the following 4 characteristics should be present. The 4 characteristics are: 1, the thin white homogeneous discharge; vaginal pH greater than 4.5; detection of clue cells in the vaginal wet smear; presence of amine odor with addition of 10% potassium hydroxide. That was the whiff test. The gold standard for detecting bacterial vaginosis is the Nugent scoring. But this is a microscopic test which has to be done after gram staining. The lactobacillus are gram positive rods, and then the bacteria which are causing bacterial vaginosis are gram negative bacilli. So you can see the change from gram positive to gram negative, and that is basically a Nugent scoring. On the left side, you can see lots of gram purple colored rods. So this is a Nugent scoring of 0. And on the left side, you see the whole thing is red with a huge clumping, and that is a Nugent scoring of 10. In between, the more it increases towards 10, the more is the diagnostic of bacterial vaginosis. So here you will get a thin vaginal secretions, pH more than 4.5, and you have an overgrowth of gram negative or variable anaerobic bacteria. But Nugent's criteria is a microscopic criteria, requires lots of slide preparations. So it is a really cumbersome thing to do. What has been made simplified by Hay and Eisen was basically categorizing them into 3 grades. Grade 1, normal, that means the lactobacillus predominate. Grade 2 is intermediate, where the lactobacillus is also there and some Gardnerella are there. And grade 3 is bacterial vaginosis, where lactobacillus are either absent or markedly reduced, and there's a predominance of Gardnerella. So we don't go from 1 to 10, it's just 1, 2, and 3 in the Hay-Eisen's criteria. And then finally, after we have done the diagnosis, we come to the most important aspect, that how do we treat bacterial vaginosis? The treatment guidelines of bacterial vaginosis are from the Centers of Disease Control and Prevention is obviously metronidazole is the drug of choice. Now there they have said 500 milligrams twice a day, but 500 milligram tablets are not available in here. So we give 400 milligrams thrice a day, and it is given for a period of 7 days. Otherwise, you can use the metronidazole gel, which comes 0.75%, and one applicator of 5 gram is given once a day for 5 days. Even clindamycin 2% cream, one applicator intravaginally for 7 days. Alternative treatments are tinidazole, 2 gram once a day for 2 days, or tinidazole 1 gram once a day for 5 days, clindamycin 300 milligrams twice a day for 7 days, or even the ovules, the clindamycin ovules, which can be used vaginally at bedtime for 3 days. It has been shown, however, that a longer therapy, like a 7-day therapy, is better than a single-day therapy to actually decrease the incidence of relapse. What is the recommended dose in pregnancy? Since tinidazole has not been tinidazole has not been studied vastly in pregnancy, and the studies regarding its use in pregnancy are limited, metronidazole remains the drug of choice in pregnancy. Key point here is that metronidazole allergy, though rare, can occur. But unfortunately, no other drug class is available to treat trichomoniasis. So if a woman has trichomoniasis, then she would actually need an allergist to get herself desensitized and then treat trichomoniasis, because the only drug available right now is metronidazole and clindamycin. Now, The next aspect is screening and treatment in screening and treat sorry screening and treatment in asymptomatic patients. Do we really need to screen? This was all about symptomatic, their treatment and their diagnosis. Now about asymptomatic patients, that means all women in labor who are not complaining of any discharge or any smell or any dysuria. Do we need to screen these women? Screening is not recommended in asymptomatic patients because the whole thing is a dynamic change. A sexual partner may change. Then after that, you don't screening and you don't. There may be some female partners. The vaginal epithelium changes because of trauma or a lot of things. So screening in asymptomatic patients is still not recommended, but you must screen and treat prior to surgical abortions or hysterectomies to decrease the incidence of PID as well as ascending infections in hysterectomies. Now you have treated bacterial vaginosis, very good, but then the woman comes back with a recurrence, and the recurrence 1 month after therapy is as high as 20 to 40%. And women, you are getting them in your OPD, they are getting irritated because the problem is coming back and recurring again. So why is it recurring? The recurrence is a result of could be the result of persistent of the bacterial vaginosis associated organism because you have not treated it completely. And second, it is also a failure of lactobacillus flora to recolonize. You go back to my previous slides, the first few slides, and that is why I stressed on the normal before going to abnormal. It is very important for the lactobacillus to recolonize to prevent a recurrence of bacterial vaginosis. So what do we have to do? Either we have to allow the the lactobacillus to recolonize, or we have to do twice weekly metronidazole gel for 6 months to reduce recurrences. So we know that recurrence is common. The treatment attempts to decrease anaerobes and allow lactobacillus to repopulate. And a common thing which we use is yogurt therapy. That's what even I recommend to my patients, that I tell them when they come with 1 or 2 episodes, and I tell them to use yogurt or curd vaginally. Even because a lot of women here, they refuse to have yogurt because they'll say thand lag jati hai, because we feel like we'll catch a cold with yogurt, especially in pregnancy. There are a lot of dietary restrictions, and the mothers-in-law will say that no, if you have curd, the baby will get pneumonia. So I recommend a vaginal application of yogurt to decrease the recurrence of bacterial vaginosis. So the current treatment options for bacterial vaginosis are basically antibiotics and antifungals. But we all know that the recurrence rate is high and there are side effects. So now what we have to look to the future, because we have to decrease these recurrences and relapse. So what we need to do is get lactobacillus in. This we can think of probiotics. If you recall that kids with diarrhea, neonates with diarrhea were treated with lactobacillus because antibiotics were not recommended for rotavirus. So they felt that if you get the gut commensals in, the diarrhea decreases. So why can't we do the same thing for recurring vaginal infections? Probiotics contain lactobacillus can be used over a long period as an alternative to antibiotics, and especially good in a context of high infection recurring rates. So what are probiotics? These are live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. So it has to be in adequate amounts. Then what are prebiotics? Prebiotics are compounds in food that induce the growth or activity of beneficial microorganisms. So prebiotics are what you are ingesting, and probiotics are what you're giving from outside. And both in combination is what is called symbiotic, and both work wonders. So what is the rationale to develop vaginal probiotics? Because we know that there is a clear hypothesis about the protective role of lactobacillus, and lactobacillus are predominant in the vagina. The application can be topical, which makes the concentration very high. And the advantage is that lactobacillus has no organoleptic considerations, because most of the antibiotics could be teratogenic. And they're easy to perform clinical trials on this lactobacillus, because you can first test it without the lactobacillus, you can apply the lactobacillus, and then again test it. So it makes it much simpler for the trials. And then, of course, it is readily available. Lactobacillus, probiotics containing lactobacillus develop a non-chemotherapeutic probiotic therapy, which maintain a healthy lactobacillus dominated vaginal flora. And this prevents sexually transmitted diseases. This can prevent preterm labor and gives a good quality of life to women. The probiotics can be inserted directly into the vagina, or they can be used as oral preparations which go from the gut to the vagina. These are especially good in women who are prone to urogenital infections or during infections. So either you're prone to it, or even during an infection, you give antibiotics and probiotics. And it can be used in healthy women as a prophylaxis to maintain normal flora. What is good about it is it can be used for a long time without any adverse effects. So let's not make probiotics versus antibiotics like allopathy versus Ayush. It's nothing as bad as that. They're both complementary to each other, but the advantage of probiotics is that it can be continued for a long time without any adverse side effects and without damaging the commensal. I mean, it actually promotes the commensal's microflora, whereas antibiotics can actually damage the commensal microflora. So this is something which is important, and this is where the rational use of antibiotics is very important. Prolonged use of antibiotics just for the heck of it, giving prophylactic antibiotics for a long time, is not recommended. Prophylactic antibiotics given over a long period can actually cause more harm than good, and giving antibiotics without any reason is dangerous. So the ideal treatment is basically providing an Indian genome specific strain or vaginal specific strains with a maximum colony forming unit of 10 billion colony forming units. Now, there have been studies which shows that biological control of vaginosis improves reproductive health by decreasing the incidence of PID and improving preterm births and increasing the decreasing the abortion rates in IVF pregnancies also. So they say a native strain will probably be better because each is suited to its own, just like native fruits are better rather than the ones we get from outside. And the right lactobacillus, which is the right lactobacillus, this what studies have shown is that lactobacillus crispatus, which has got a good H2O2 production rate and it causes its ratio of normal is to disturbed is good, is probably the best as accepted lactobacillus for the vaginal flora. Now, this is a whole lot of information, I think, which I have just shared with you. But what I would like to state is that bacterial vaginosis is something which is frightening because of its various implications in obstetrics and gynecology. Bacterial vaginosis can be decreased to a certain extent if you're aware of what is normal and what is abnormal. And it is high time we started considering this entity so as to improve the outcomes in pregnancy and decrease the incidence of PID and infertility. And last but not the least, it is very irritating for the mother. So it is, I think, it would be it would be highly beneficial for a woman's outcome if we could consider treating her bacterial vaginosis and preventing recurrences. Thank you.
Thank you, ma'am. Thank you for your wonderful presentation, ma'am. Ma'am, with your presentation, I can able to understand that the importance of female microbiota in human reproduction and fertility, and a better knowledge about the vaginal microbiota prior to IVF may help both couples and healthcare professionals decide on the timing
Yep.
of their IVF. Yeah, thank you, ma'am. Thank you very much. And it's always a honor hearing you, ma'am. Madam, I will read out if there is any questions in the comment box. So let me wait for 2 to 3 minutes for the participants to post their queries, ma'am. Ma'am, I have one question. How will you treat bacterial vaginosis in first trimester of pregnancy, ma'am? What will be the safe treatment in first trimester?
Yeah. This is really controversial because you cannot give metronidazole in the first trimester of pregnancy, and whether orally or vaginally. So I think, as I said, the best thing here would be to improve the commensals. So I think if you can give lactobacillus here, you can decrease the, you can improve the lactobacillus to actually decrease the organisms which cause bacterial vaginosis. But however, if the woman is symptomatic and this is it's itching and she's got dysuria and all, then you would have to really consider vaginal applications of metronidazole, a single shot application of metronidazole.
Okay, ma'am. Ma'am, whether the endometrial microbiome have any impact on embryo implantation and pregnancy maintenance, ma'am? Endometrial
Yeah,
microbiome.
definitely. Because we have endometrial receptivity. We have an endometrial receptivity to the embryo. So microbiomes everywhere are useful for proper functioning of that area, for that tissue. So whether it is a vaginal microbiome for the vaginal epithelium and the endometrial microbiome for the endometrial epithelium, everywhere the normal versus the pathogenic, the good versus bad, is imperative for a proper functioning.
Okay, ma'am. Ma'am, is there any relationship with women who are obese? Whether this microbiome play any role in the obese patient, ma'am?
See, nowadays gut dysbiosis is also a major factor. So gut dysbiosis, again, nutrition plays a major role in obesity. It plays a major role in polycystic ovaries, and it is also stated that it produces a major role in developing type 2 diabetes mellitus and GDM. So gut dysbiosis is a big factor in all these things.
Okay, ma'am. Let me wait for 2 minutes, ma'am, for the participants. They also need to post their queries, ma'am.
It is not, I don't think it was very controversial, because I just stated something that we really need to contemplate and we really need to look into, because certain diseases, especially now preterm birth, is becoming quite a problem. As I just said, we just had a webinar on preterm labor, and it's the prevalence is really increasing, and we really need to introspect into this. PIDs are becoming common. Postpartum endometritis, which was something we hadn't heard of much when we were in medical college, this is also coming up. A lot of seniors probably never encountered postpartum endometritis, and then suddenly now it's an entity. So these things are coming up probably because of an irrational use of antibiotics, which is damaging the normal bacterial flora and leading to these problems.
Okay, ma'am. Ma'am, I could not find any other questions in the chat box. So if you all
I can see Dr. Usha Nath ma'am here, and I would like, she's a very senior doctor from Ranchi, and I would like her comments about how she feels with all these years, the incidence of various diseases has risen, and what in her opinion has been the cause. Dr. Usha Nath ma'am has unmuted herself. Good evening, ma'am.
Good evening, and thank you very much for talking. Actually, I must congratulate you, because it was so good. I couldn't believe that you have given such a focused lecture about the vaginal infection or microbiota. So, what is my experience? You have asked. Yes, the vaginal infection is on rise in my experience, and the women get repeated infection. And you said that there is no need to treat the partner, but I have been when I see that the patient comes with a repeated infection, I usually give a course to the husband also, and that settles the matter in my experience. The secondly, what I found that you recommended metronidazole to use for only 7 days. But since I have been working in UK for a long time, I learned there to treat for 10 days, and I have been continuing to do that. And it does give a good result. So I asked this question from you in the chat box, that what would you say to this?
Yes, ma'am.
Yeah, absolutely. In fact, ma'am, thank you for raising these points, because in fact, it is the recommended treatment schedule went up to even 14 days for metronidazole.
Yeah,
They said that
sometimes,
if you give a
yeah.
prolonged, yeah, up to 14 days can actually prevent. That's why I said a longer therapy prevents relapses, is beneficial for preventing relapses. And the male partner does not have the bacterial vaginosis, so it's like, it is not like I'm treating the male partner will prevent the woman from getting bacterial vaginosis, but a simultaneous treatment of both will cure it at that time. But if I just say I treat the male partner and then I say, okay, the woman is not going to get bacterial vaginosis, that does
No.
not, she's not going to get
No,
so
we won't say
simultaneous,
that.
yes, yeah, that is what I meant at that moment. Sorry, I think I couldn't get it clear across. Very good of you, ma'am, to ask that question. Simultaneous treatment is important, because treating the male partner is not preventive for the women.
Yeah,
Uh-huh.
true. This is right. What I have been thinking all the time, that what is the reason for the woman to get the bacterial vaginosis? What is the reason, true reason? Lactobacilli, you said that the less lactobacilli or the recolonization of the lactobacilli is the cause after the infection. But, without that also, can you say that there is some other reason for which the women get it? And especially in the pregnancy, I have just now a pregnant early pregnancy patient who have this intermittent discharge, pain, and the high vaginal swab is always negative, nothing is there. So how do you treat such patient actually? So there are two questions for you. What could be the more reason for women to get the infection? And the secondly, if the high vaginal swab is negative, you have to do empirical treatment. So what do you do in these cases?
Ma'am, I would say choti muh badi baat for myself, but I feel that this is my personal opinion. I mean, I could be absolutely off the track, but my personal opinion is the reason that women today are getting more, we are getting a higher incidence of vaginal infection compared to what we got 20 years back, is because one, some kind of dietary indiscretions. By mal, I don't mean undernourishment. Malnourishment. It is the change in the whole dietary pattern which is causing a lot of gut dysbiosis. That is hampering a lot of. It's creating a lot of hampering of the gut movement, the gut peristalsis, the gut bacteria, and that is very important. Secondly, is that I think the environmental toxins are also creating a lot of havoc in our body. So because these are the only two things which I see are changing. If you see, the nutritional aspect has improved, in the sense that, forget about the malnutrition, in the sense the nutrition is, we have additives in our food, all those qualities in our food are lost. But the cases we used to see when we were in medical college of marasmus and kwashiorkor are no longer seen. The pot-bellied kids with brown hair, so that has been taken care of. But these two, in my opinion, are very important. Then another thing I see are rampant use of antibiotics. Even for simple viral fever, people will give antibiotics. Patients are demanding antibiotics. See the number of antibiotics kids get nowadays for simple things like diarrhea and fever, when everything is probably viral and can be controlled. So these are a few things in my opinion, which are changing the scenario. And the second question was, high vaginal swab is negative, and yet she has pain, and she has frequent discharge.
Yeah.
So pain could be anything
Discharge.
from vascular congestion. Yeah, pain could be anything from a vascular congestion to in early trimester, to even something, an abdominal problem. So we should exclude other factors like, say, um, vulvodynia. We should exclude constipation, because all these also causes a sense of heaviness and pain. Then even pelvic congestion leads to a lot of pain. So all these facts should also be, I feel, excluded when we are actually examining the woman. And sometimes that pain and heaviness is also I mean, I'm not, but sometimes it is also a psychological problem, because she is under immense stress. That leads to a lot of norads and adrenalines being secreted from a body. And all those also cause a lot of vascular imbalance. That can also be another cause of pain, in my opinion. But as I said, choti muh
Well,
badi baat.
No. I was amazed. I mean, thank you, Dr. Nivedita. You have given such a beautiful answer and to the point, both to my both questions. And just I want to add a little bit to the first one, that yes, these days the people are using a lot of, cleanliness or whatever chemical in their bath.
Yes.
Good smell and all these things. So that also gives rise to, favors the infection. And in the second, what you said, a lot of stress. Yes, in the early pregnancy, when she has first miscarriage and this is her second pregnancy, she is in in-laws place. So there is a lot of stress if something going to happen to this pregnancy. So that also can cause this kind of happening. So I'm really thankful you just put the finger on the real, answer.
Thank
And
you, ma'am. Thank you for
I will
coming and
keep in
attending this.
mind. Thank you.
Thank you.
Yes,
Thank
I
you,
would
ma'am.
have. I would have. I did as soon as I saw. I registered myself because I wanted to hear you. You are such a beautiful speaker. You give a
Thank
beautiful answer and beautiful way to speak and explain. Thank you.
Thank you, ma'am.
I
Thank you,
enjoyed.
ma'am. Thank you, ma'am.
Thank you, Sharat madam, for your presence and sharing your few valuable points with us, ma'am. Thank you.
Thank you.
And yeah, ma'am. So, ma'am, shall we end the webinar today, ma'am?
Yeah. Thank you. Thank you, Dr. Stalin. Thank you, Team Shield, for giving me this opportunity and a really good learning experience. I
Yes.
learned while preparing the slides, while reading the slides, I learned this. I mean, the slides were theirs, of course, but reading the slides, going through the matter, it was really, each and every webinar has been a learning experience for me. Thank you, Team Sheila, and thank you everyone, and especially a big thank you to Mujana.
Okay. Okay,
Thank you, ma'am.
bye.
Thank you.
Thank you,
Bye.
Norman.